listen to Dr. Vassiliou now. Melina, where are you? There you are. Okay, I want to introduce Dr. Vassiliou. Now, Melina has been our voice of reason for the last several years, okay? And when we get in the room and, you know, Carla and Lisa are wondering what we're doing, and we have Melina there to kind of tell us what's right, what's wrong. And Melina is an assistant professor of surgery with a lot of, obviously, past knowledge in both endoscopy and surgery, but also in education, and working now with Dr. Fried again back at McGill University.
I don't think I've ever been referred to as the voice of reason before, but thank you for that introduction. So I'm going to talk mostly about, some of the stuff is repetitive, but you know, you'll hear about it in a little bit more detail here. I have nothing to disclose. So I'm going to go through how the manual skills component was developed, perhaps in a little bit more detail, although Brian did run through most of it, and Jeff did a review of validity and why it's so important. To describe how our validation process has been going up to date, and to share some of our data with you. So the manual skills component of the FES exam, as you know, was developed by a subcommittee formed of members of the FES task force. And at our Muffin retreat, we developed that deconstructed task list, and also worked on the development of the gauges assessment at that point in time. And then this deconstructed task list was really what we used as a guide to then go on and choose the platform, and they went through sort of the process that was involved with that, about putting out requests for proposals, having a simulation fair, and finally culminating in the selection of partnering with Symbionics for the GI Mentor. Here is the deconstructed task list that we came up with at that time, and as you can see here, these are sort of some of the things that we wanted to model and measure in the manual skills component. So, and despite the higher costs, as was mentioned, the decision to go with a virtual reality platform does have its advantages. Of course, if any of you have worked with flexible endoscopes, even in an animal or environment, it's very arduous to try and clean and reprocess the scope, so there was really no need to do this. The simulator came with a proprietary scope. And all of the data collection and standardization that is really essential to a high-stakes examination could be done with this computer and centralized interface, as well as the collecting and reporting and administrating of data directly through SAGES and their software platform. There was a commitment by Symbionics at that time as well to make a more affordable version of this platform. So we cannot stress enough how important validity is to this whole process. For a high-stakes examination, where the implications are determining whether or not somebody is proficient in a task, you really have to make sure that you abide by the highest standards. And there is a manual put out by the American Educational Research Association, American Psychological Association, and the National Council of Measurement and Education manual that's pretty much the Bible of test development, and pretty much the Bible that most other high-stakes examinations refer to. And I know Jeff mentioned that some other examinations, particularly in medicine, have not necessarily followed these rules, but I think that they really probably should have, and so these are really the sort of Bible of what should be done in terms of validation. And first, it starts with the reliability. So the reliability implies the consistency of the test measurement. And in our case, there will be some perhaps internal consistency, things that we will measure with the simulated tasks. But because of the simulation or computer-based platform, we didn't have to worry about measurement errors between different raters. And so the inter-rater reliability component that was important for the FLS, because it was being scored by an actual person, really is out of the picture for this computer-based assessment. The next slide sort of going to talk in a little bit more detail about validity, which is derived from the Latin term validus, which means strong. And this is a quote from the manual that I referred to from the American Psychological Association. And validity is essentially the most fundamental consideration in developing and evaluating tests. And if you think about it, if a test isn't valid, it really doesn't mean anything. And it's the degree, essentially, from a psychometrician point of view, the degree to which evidence and theory support the interpretations of test scores entailed by proposed uses of tests. essentially it just means how close is this test or the results of this test to measuring reality, or what we're really trying to measure, how true are these results? How close are we really getting to measuring the essential skill set of flexible endoscopy? And the validation process is really a multi-layered process that sort of puts together different pieces of a puzzle that all contribute to the validity or the whole validity of the piece. And it starts out with certain types of validity which have obviously more clout or more weight than others. Face validity is sort of if a group of experts look at something and say, well, at face value, it sort of looks like, yeah, it kind of looks like it would measure what it's supposed to measure. Content validity as well is something that is often derived from expert opinion, and it's really about how comprehensive an examination is, whether an examination includes all of the components that are seen to be essential for a given skill set. Construct validity is one we refer to often in medicine, and one type of construct validity is known groups validity. And we do that by assuming that we have a group where we know something about them, and we predict based on what knowledge we know about them how they'll perform. And so we predict that novices should perform less well than experts. Criterion validity is composed of concurrent validity, which uses other measures and at the same time as one measure and relates the two. If something is supposed to be measuring a given construct, then if you're measuring the same thing or something similar, they should be related somehow. And finally, predictive validity is what we've referred to all along as well, is sort of performance on one, in one area can predict your performance in another, so how they're related. And I'll go through a little bit more detail about that stuff. And finally, external validity implies the generalizability of the results. And I'll go through that in detail too. So for face and content validity, as far as the manual skills component of FLS goes, face and content validity really is about the process that we use to develop the tasks. So content experts, expert endoscopists, everybody from the FES task force, and everybody in the committee that went through putting the content, creating the task list, working with Symbionics to create the tasks, reviewing the tasks, going back and forth, deciding what should be in there, what shouldn't be. All of that is a process basically of face and content validity. Then the construct validity component, which is probably what I'll focus on most in terms of the rest of this discussion, is the comparison in performance between novice and experienced endoscopists. And criterion validity, I think Dr. Fried will speak about in more detail, would really be for the future after we've done that construct validity component to use the operative assessment to correlate performance in the simulator with performance in the operating room. And finally, the external validity component is really embedded within the design of the validation as well, in that not only are we using it across different specialties, so with gastroenterology and surgery, but also across multiple centers throughout North America. So these are the two gauges tools. I'm not going to really go through them in detail, and this was a work by the whole FES committee essentially, so that we validated the assessment tool. And then we used the tool to try and, this is some work that we presented at the ASE last year, to try and determine, although we're trying to get away from numbers, in order to do our validation study for the manual skills, we had to find a way to kind of define our novice and expert groups in terms of upper endoscopy and colonoscopy. So we actually used this gauges data to try and say, well, for upper endoscopy, the plateau of this curve seems to be, so these are gauges scores, total gauges score here, and a reported number of cases, and it seems to plateau around 50 cases for upper endoscopy and around 75 for colonoscopy, and this helped us to define our novice and expert groups for the simulator. So, and I'll share some of this data for you, and some of this analysis is planned but has not yet been done, because of course we don't have all the data, but conceptually the idea is just to have a look at, to see if we created scatter plots to see if endoscopic experience correlated with some of the error and time scores that we were measuring for each of the tasks. Then we compared novice and expert groups as they were defined. Then created, the idea behind all of this is after we get all of this error data, precision data, time data, to try and interpret all of that and to put it together into some sort of meaningful score that's weighted with depending on what we're measuring. And the things that you can measure in this virtual reality interface are clearly unlimited, so we have to try and figure out what is important and to what degree is it important depending on how the different things perform. And then eventually to correlate these with gauges, as I mentioned, probably using a Pearson's correlation coefficient, and then to determine passing scores in the end of all of this. So it's quite a process, as you can see. And I'll share with you some of our preliminary data. So we've we've tested about 33 people so far, probably a bit more at this point, across 4 different sites. 26 were surgeons and 5 gastroenterologists, and 2 didn't write what they were. And the different groupings here, one of the tasks, task 3, as Jeff went over, is upper endoscopy tasks. So we define the groups based on their experience in upper endoscopy. And the rest of the tasks we use lower endoscopy. So you see here 14 novices and 19 experts, and here 22 and 11. And I'll just share with you data for 2 of the tasks, although we have gone through each of these for all of the tasks. And this is the first task, scope navigation. And it does look at some things like tip deflection, scope traversal, torque, and use of two-handed technique. And the simulator measures, I'll just show you data for 2 different things. So for sure the simulator is going to measure time. So how long does it take someone to go through the simulation and match up all the targets? And as you can see here, this is plotted against a reported number of cases, so as experience, and time in seconds over here. And as you can see, the curve essentially looks like it should look. More novice participants took more time to complete the task than more experienced participants, and this was statistically significant. Scope navigation also records the number of times you touch the wall, and participants are guided before they actually perform the task to try and not touch the wall. And so we would assume that novices have a harder time with this than the more experienced candidates, and as you can see, they do. And this result as well was significant. So although we would like to have more data points and more ways of measuring the actual components of the skill, now that we have something that can incorporate time and precision, then we can start to think about creating a score for this that's normalized based on some expert data. And so through a simple formula, we can create a score where essentially the more experienced you are, the higher you score on this task, and just playing around with the data. In this way, we're able to create a score that essentially shows a significant difference between novices and experienced. And this may change with time. We're still getting more data on this task, but it's just as an example of where we're going with this for the other tasks as well. So this task actually performed the best of all the 5 tasks. And I'll go through this upper endoscopy task, which actually performed the least well among the 5. And we're still in the process of trying to figure out why that is. And we wanted to include an upper endoscopy task because especially for skills like retroflexion, traversing a sphincter, and working with insufflation, these tasks weren't well represented in the other tasks. And as you can see here, the time for the upper endoscopy task doesn't differentiate as well between novice and experienced participants, although there is a clustering here of novices who took more time. As you can see here, doesn't really turn out to be statistically significant. It seems like it's trending in that direction, but certainly not as tight as the data for the first task. And this overinflation was one of the error measurements for the upper endoscopy task, and it didn't seem to work the way that it should have. And as you can see, a lot of the novices did not overinsufflate at all, and some of the most experienced participants seemed to overinflate the most. And so this was not a significant differentiator between the experts and novices. And we have to go back to the drawing board a little bit with what we're measuring and what it actually means. And some of the feedback that we got from experts who did participate in the study was very positive. They really liked the task 1. They found it was realistic. Some of the other tasks they became quite frustrated with, which I think is good feedback for us, especially in that upper GI task. As Jeff mentioned as well, time might not be the thing that we want to measure the most success, especially for tasks like mucosal evaluation, where it's not so important how fast you pull the scope back, but more important how thorough your examination is, and whether or not you can actually see around corners and identify targets. And this is a complex process to try and develop, because it's really an unstructured thing to try and tell Symbionics what we are looking for and what we're trying to measure. I think is a very difficult process to go through, and this pilot data has helped us a lot in terms of coming to some realizations with regards to that. I think the platform is a wonderful platform. It's clearly going to work. It's easy to administer. It's practical. It's quick. And I think we just need to work a little bit more on tweaking some of the metrics for these tasks. In particular, the insufflation has been challenging. So in summary, scope navigation does demonstrate construct validity. We do need to modify some of the other tasks, and it may be an issue of script, and maybe an issue of instructions of what we're telling people at the beginning of the task and how much information we're giving them in terms of what our expectations are. And we're looking now to try and get more data out of the simulated tasks to actually see what data, what can be measured and what's going to end up differentiating between novices and experts. So I think the FES manual skills include all of the important things. They demonstrate face and construct validity of what we need to measure. And the skills will undergo this rigorous validation process and meet the highest standards possible. And once they're validated, this is really going to be a valuable tool to contributing to the definition of what it means to be competent in flexible endoscopy. I would like to thank everyone on the FES task force, and in particular Lisa, Carla, Sarah, and Jessica, Peppa, and Yo at McGill for all of their support. And I would like to thank Brian and Jeff as well for the opportunity to be a part of this process.
Thank you, Melina.